corrected the issue. So welcome everybody to Playbook Live. We're going to redo this whole thing again. Again, we're really off the cuff and casual here, so not a tech expert. Stuff happens. So anyways, I got two guests coming on tonight. We're excited to bring them on. We're going to be covering a great topic. We touched on PCR testing last year, and now we're going to kick it up a notch and bring it more into the application of using it for real out there in the real world. So we're going to kind of help get that going. A couple of things I did mention, I'll bring it back up again. Philadelphia is almost sold out. Salt Lake, Kansas City, and Milwaukee still available. And then the other thing you didn't hear me say is that we do have another webinar scheduled for you. Details to be announced soon, but it is going to be on April 14th. So put that on your calendar. It'll be at 12 p.m. Central Standard Time. And my incredible partner, the Mrs. Smith of Wound Care, Denise Richland, is going to be the presenter. And you are going to love this topic. It's going to be one you'll want to share with your colleagues. And this is going to be some just really great information out there. So definitely want to plug into that if you are available on that day. As you know, with all of our webinars, if you pre-register for them and they are free, you will be able to access it later after, still for free. So kind of keep that one in mind as well. So with that being said, I am going to bring up my two attendees for this evening. I'm going to introduce to you Therese Laub and Dr. Richard Adams. How are you guys doing this evening? Welcome to Facebook Live.
Doing well. Very exciting stuff here.
Excellent, excellent. And how are you, Dr. Adams?
I am doing great.
Excellent, excellent. Well, I'm excited. So what I like to kind of do with my my interviewees is to have you tell us a little bit about yourself and your background. So I'll start with you, Therese. Why don't you kind of give our audience a little bit about your background and stuff like that?
Okay. Well, I am a certified wound care nurse for about 20 years now. It's been a while. Board certified through the American Academy of Wound Management. I probably was one of the first out there. When I got certified, they weren't even requiring a test to become certified. A lot more than that now, but I've been doing a lot since then. A lot of experience in home health. I was consulting with a lot of the agencies in the Chicago area. I helped start a wound care clinic here in the Elgin area outside of Chicago many, many years ago. But that was an amazing experience, just the whole process of getting that going and then being a part of opening it up in a hospital. And it was real exciting stuff. I've also worked with a DME company out of the Chicago area. So I was a clinical consultant and support for their marketers with the Invia, which was made by Medela, which I think they still have that now. Mm-hmm. And then I was working in the long-term care industry for a number of years, assisting wound management providers doing helping them with making recommendations for dressings and topical treatments and support surfaces and all that good stuff. So yeah, I've been doing a lot with wound care over the years.
That's good. Excellent.
And exciting. Yeah.
Awesome. How about you, Dr. Adams? What can you tell our audience a little bit about yourself?
Well, I'm afraid my resume is not quite as lengthy as Therese, but I have been in private practice as a podiatrist for 30 years. And anybody who knows anything about podiatrists knows that we see quite a bit of both diabetic and non-diabetic wounds, whether that be in the emergency room, post-surgical, or again, our diabetic patients. I do have a little bit of experience working in a wound care center in Houston before I moved up to the Fort Worth area. Yeah. And again, we certainly enjoy our diabetic patients and try our best to get them healed.
Excellent, excellent. Well, I want to welcome you both on our program. Again, it's as I always tell my interviewees, it's a very relaxed, easygoing atmosphere here. My audience that are out there, again, at any time, please type in your questions for our guests tonight because they've agreed to take any and all questions. So
Absolutely.
and so you get to totally catch them off guard. They're not screened, so we'll really put them on the spot tonight, But it's always good because we have a lot of fun with it. So throw your questions in if you have them. So with that, let's get started here. I'm going to start with you, Therese. Obviously, you're with Ability Diagnostics, which is kind of the company that we're sponsoring here this night as far as part of this program. And so what is your role at Ability?
Right. So Ability Diagnostics got started with PCR testing in the onychomycosis arena with the nail fungus, right? So they did a lot of work with the diabetic population with podiatrists out there. And it started to become a realization that wounds were a big part of diabetes and what podiatrists were treating.
Right.
So what they decided to do was look more into, PCR testing for wounds, since it was such a needed thing out there.
Sure.
So they wanted to develop, wound care division once they got the machines validated to do those specific tests for wounds. And they wanted to, have people on the team that included not just, people in the lab that were looking at slides, but the clinicians there that could help with the other part of it. So we have Dr. Bullock, who is a pathologist, infectious disease, and he's a board certified wound physician as well. And they wanted to expand that. So they hired me as a clinician, to help round it out and make it more of a team effort as opposed to just, a lab.
Sure.
So I'm working, as a clinician, but helping with the development of the wound aspect of it, with education, with development, training, that kind of thing.
Mm-hmm. Excellent.
So,
right, cool.
Yeah.
So with that, then, obviously, how is your company working with clinicians to incorporate the use of PCR testing into their practice then?
Right. So like I was saying, is we were looking at a more well-rounded focus with the testing. So we were looking at more of a partnership or an alliance with the providers that are out there that are treating wound patients. So what we're trying to do is help, like, the agencies, home health agencies that are out there, wound clinics, facilities, and practices, incorporating a program that's helping with identifying infection to help the wounds heal.
Gotcha.
So even though we're providing that service of PCR testing, it's becoming a part of a collaborating team that we're really focused in on. So, when you look at anywhere really that's doing any kind of wound program, or any clinician that's treating a wound, we all know that it's not just one person doing one thing with the wound.
Right.
It involves a lot of different aspects.
Sure.
And infection identification, I feel, even as a wound care nurse for 20 years, is one of the more critical aspects, right?
Right.
Because you're not going to get something to work unless you've got a clean wound to either apply it or use or whatever,
right.
Or surgically intervene or whatever. So we're trying to bring that focus to the clinicians and helping them identify situations where PCR testing is really necessary, I would say.
Mm-hmm.
To help the wound heal, or to go to the next level of what they're looking to do with that wound.
Gotcha. Okay. I know, like I said, we had a previous guest on a couple of interviews ago. He was an infectious disease doc, and the title of the program was, "Is the Wound Really Infected?" And, a lot of times they're not, yet they're treated as though they are. So passing it to you, Dr. Adams, how are you and your colleagues utilizing PCR testing in your wound practice?
Well, it's actually been a pretty good boom for us, because with standard culture and sensitivity, we can determine what bacteria is involved, and we can determine generally which antibiotics we can use. And of course, there's bacteria that's wound colonizers, but there's also bacteria that's an infecting agent.
Sure.
Although the infection is much more severe, the wound colonizers can certainly slow down formation of what we call the granulation base, which is, of course, where we can then overlay a skin graft or get healing of the native skin.
Right.
With the PCR testing, not only can we identify the bacteria and generally which antibiotics will help to kill that bacteria, but we can then contour those antibiotics directly into a combination of topical antibiotics and, if we prefer, in tandem, oral antibiotics.
Okay.
And for us, it has been nothing short of fantastic working with Ability Lab and their collaboration with the pharmacy that we use.
Okay. Cool. Excellent. 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 So I know you kind of touched on this, Therese, but when you're talking this collaborative approach that you guys are doing, who is all a part of that collaborative process to make it really function optimally?
Right. So of course the provider at the bedside, right? The person that's there with the patient, looking at the wound, making the recommendations for the dressings. But it's also working with the companies that are providing some of the either the biologics or, let's say, the negative pressure. The surgeons that are going to be doing a flap or some kind of surgery on the wound. It's also working with them to help them prepare that wound bed for what they're about to do, right? Because a lot of those procedures are very expensive. A lot of those biologics, could be thousands of dollars, right? So you have a wound that may not be, prepared for that,
right,
because there's an underlying infection. So it's in everybody's best interest to make sure,
right,
that that's clean.
Sure.
And just to go back from what you had just said, I know you had mentioned that a lot of times a wound, you may be tested and it's not infected. But what we see a lot of times too is that there's an infection that is not being recognized.
Sure.
So there's a lot of, signs of infection that we all know, the redness, increased drainage, the odor, the whole thing.
Right.
But there's a lot of times when a wound can be infected that you don't know. There's no signs that are showing.
Right.
And the only way to really tell is if you do a test to see. And we know that as wound care nurses and doctors, a wound that's not progressing, 2, 3, 4, 6 weeks, even though it looks like it's not infected, a lot of times there's a biofilm or there's a bacteria or sometimes even fungal issues that are going on that are
Right.
preventing it from progressing,
Sure.
right?
Yeah, unfortunately, those little buggers, you can't just see them.
Exactly. It'd be a lot easier if you could, though, right?
And let's be honest too. The biofilm is a pretty hot topic out there.
Yes, it is.
But if we're going to be honest about it, rarely do you actually physically see a biofilm.
Absolutely.
And I have people, again, I teach wound care all over the country, and I get the stories of, oh yeah, we sent him out to the wound clinic and they sharp debrided the wound for biofilm. I'm like, they sharp debrided something they can't see? That's impressive.
That's right. Right?
You
want to know that magic.
And I'm like, did they do something in advance to confirm it before they just hack that wound bed all up? And
that's
the problem
the key
is
right there.
Well, the challenge is, even again, the only thing currently right now that can definitively confirm a biofilm is confocal laser scanning microscopes. PCR, I know, can tell you all the bacteria, but it cannot definitively say that there's a biofilm in the wound. But at least you can, with a PCR testing, at least you can hone in on the bacteria that are most likely the problem and more direct your treatment. But, this blanket statement of people like, oh yeah, I just debrided the wound for biofilm. I'm like, how do you even know it was there in the first place? I think we need to do a better job at that. But again, I'm a huge fan of the advances in the technology with this. So let me ask you this, Dr. Adams. How often would you say that you and your colleagues are using PCR? And what criteria are you usually using to determine if PCR would be helpful?
Any difficult wound, we just automatically now have shifted over to PCR.
Okay.
In other words, if we get a standard a patient who comes in with a simple diabetic wound,
Mm-hmm.
and the debridement, local wound care, and the oral antibiotics are doing the trick,
Right.
then we're fine as long as we're making progress.
Right.
And as we all know, sometimes the wounds will make progress. Sometimes they stall for a few weeks and then they come back and start to heal. But anything that looks like it's giving us a little bit of difficulty, anything that seems like it's taking its time, that it's dragging out, the PCR has been very helpful for us. Very helpful. It gives me another avenue, another angle to look at to see what may or may not be causing the stalling effect of the wound, assuming the circulation is adequate,
right,
and of course the glycemic control is accurate.
Right. I mean, you're looking at the obvious things and just kind of ruling them check, 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 and then when you get down to the biofilm or the bacteria, which you can't see, you're like, all right, I got to do something to clear this one off the bench, so to speak, to see if it is the problem or not. So no, that makes total sense. It's a lot of times, unfortunately, with those stalled wounds, it's a process of elimination to figure out what the problem is, because it's not always, there's no big neon sign that's blinking at you that says, hey, I got a biofilm.
Right.
Never is.
It would be really nice if there was an easy button like Staples has where you could just
Yeah, and again, that's where experience comes in, and the fact that we practice medicine.
Right.
We don't have all the answers.
Exactly.
And it's a process of elimination sometimes.
Yep, exactly. Excellent, excellent, excellent. So back to you, Therese. How do you then, from your perspective, how do you see the PCR being used to develop the actual treatment plan? So when they get the PCR test back, you got your results. What does that then lead to as far as treatment plan implementation?
Right. So the results are going to show, the bacteria and the fungi that are being picked up at the genetic level, right? Okay. Not only that, though, is it's telling you they're resistant genes, which is a very critical point of what PCR is doing for you. This is what really is guiding these antibiotic stewardship programs. I mean, that's another buzzword right now, and everybody, especially since COVID, is really focused on what's going on with antibiotics. Sure. We've gotten ourselves into a real problem here over the years. So when you look at PCR and getting these resistant genes, now you're looking at a targeted antibiotic that's going to address that bacteria. Without trying this and then it doesn't work and we're going to try that, giving the bacteria time to mutate and turn into something that's not quite as, resistant, or that is resistant then more to the antibiotic. So this testing and getting these type of results, it's going to drive, a more targeted approach to the antibiotic that's chosen. And as Dr. Adams had mentioned, and we'll talk a little bit about this because I have a little chart we're going to put up, but there's also the option of this with using a topical antibiotic as opposed to just oral or systemic. We treat a lot of wounds that have poor arterial perfusion in the feet, whether it's diabetic or PVD or PAD. We have people that are not candidates for systemic treatment, whether they have GI issues or allergies or whatever. So this other option has been proven to be very effective for these kind of patients, because you're able to just put it right there, right where the issue is.
Sure. Now, just kind of to go along with that, Dr. Adams, because we talked about, you mentioned the topical antibiotics, and so did, Therese. My question would be, and just kind of one that just popped in my brain, so I'd like to get your input on it. Obviously in speaking with our infectious disease doctor, and then I was also watching a webinar by another physician, and when they do topical, they're not using your typical off-the-shelf stuff. They're actually having them compound them to strengths that are way higher than you would normally get in an off-the-shelf. Is that what you guys are using too when you say topical antibiotics? You're not just buying a thing of triple antibiotic.
Oh, no.
And because I know the research on those and the evidence is really crappy. Okay. So I was just curious if you're having them compound you stuff where you get, significantly higher dosages. Is that correct? Is that am I right
That
on
is
that?
absolutely correct.
Okay.
Right. What we want to do again is we want to target the infecting organism, because with the oral antibiotics or with IV antibiotics, we might wipe out some of the specific bacteria that may compete with the affecting organism that could actually slow it down.
Sure.
And so by using a detailed laser focused topical antibiotic, you might call it,
Right.
we're killing the infecting organism, but again, we're not damaging that may be advantageous as time goes by.
Excellent, excellent, excellent. So let me ask you this, since I've got you, Doc. So what kind of benefits have you seen real life in the outcomes when you've been using PCR testing as part of your assessment of your wounds prior to treatment? Are you seeing some really good outcomes overall? And what types of wounds would you say that you're seeing the best results?
Well, most of mine, of course, is anecdotal. Although we have discussed working on a study where we can actually do something double blind. In this particular circumstance, I have seen accelerated healing rates. For example, I had one lady recently who ruptured her Achilles tendon, but it ruptured out of the skin.
Okay.
And so what then happened was she ended up with a gaping wound. Even though we were able to repair the Achilles tendon, that wouldn't heal.
Right.
So fortunately for us, she had very good blood supply, but of course, the Achilles tendon does not have good blood supply. The utilization of the topical antibiotics, we were able to reduce or eliminate those bacteria on that Achilles tendon graft, whereas if we used simple oral antibiotics, it never would have penetrated.
Right.
So from a practical perspective, we're seeing what I would call a significant reduction in healing time.
Excellent.
We're not blind treating this. We
Right.
now have a target with what we're looking for.
Yeah, that's awesome. I mean, because obviously, the more specific you can be, the more effective your treatment is ultimately going to be as well too. So, excellent. While we were talking about, we had a couple of questions pop up, Teresa. I'm gonna throw them to you from our audience. What does What does PCR stand for?
Yes, I should have said that right from the beginning, right?
Sorry.
It's a polymerase chain reaction.
Okay.
That's what
And
the PCR is.
got it. And the follow-up question is, how much does a typical procedure cost?
The test, you mean?
The test, yeah. I'm assuming.
Okay, and yeah, that's a really great question, actually. So our tests are covered under Medicare Part B and a lot of commercial insurances. So it's almost just like doing a regular test through a lab. It's not anything that's, above and beyond. We have the codes to bill and that kind of thing. So honestly, there's really not a reason not to use it as far as the financial aspect goes.
Sure.
It would be the same as it would with any other.
If I might add from a practical perspective, I'm sure Therese knows how many patients we've used for this, but we haven't had any complaints on that. Okay. Not one about the cost of the procedure.
Okay.
Mm-hmm.
Yeah. And I'm just curious, if a person had to pay out of pocket, what's a ballpark cost to have that procedure, that test run, just out of curiosity, if you can throw a number out there? I won't hold you to the exact penny.
Well, I can be honest with you. I'm not 100% sure. I think it probably between a 150 and two.
Okay.
I think.
Yeah, that sounds about right. Obviously,
Yeah.
I was just kind of, just in case somebody's asking, because everybody I mean, I know for myself, just, little personal testimony, I get my labs done. I pay for them myself because it's cheaper than going through my doctor's office, who I get charged like 3 times the amount when I get the bill from the lab. I'm like, I can hire this private company, pay out of pocket, and cost me a third.
Right.
Why do I want to run it through my insurance when they won't even cover it?
A lot of
as long
people,
as we're
though,
on the topic of cost too, topical medications over the past several years have gotten a bad rap for being terribly expensive, thousands of dollars.
Hmm.
And I can tell you that I don't think my patients have paid more than $40 or $50 for a copay on the topical antibiotics, even the ones that are custom fabricated.
Okay.
So again, I don't want the audience to get confused with those $3,000 topical prescriptions. We are not talking about that whatsoever.
Okay. All right, good. Now, we got questions rolling in. So how do they collect the specimen? Either one of
That's
you
a great
take that
question
one.
too. Dr. Adams, do you want to cover that?
Well, yeah. So I often joke with my patients that I do body and fender work. So my simplistic approach here in the clinic is that, again, I will, depending on the depth of the wound, I'll usually try to do a culture before I do any debridement. However, sometimes after my debridement, if I found an abscess or if I found some type of a sinus tract, then I'll simply dispose of the first culture and I'll culture deeply. It doesn't cause any pain to the patient. Basically, it's a swab. However, once the swab is treated properly, we can get a wealth of information from that.
And my understanding is that they generally recommend the Levine technique when they're taking the sample, when you're doing like from the wound surface. Is that correct in my understanding? Versus the normal zigzag Z stroke,
Right.
W stroke.
I think you're going to get a truer result if we can get either a little bit of tissue or fluid from within the wound.
Right.
Because the one thing PCR will pick up are anaerobe bacteria, where you're not going to get that with standard culture and sensitivity, right? So I think it probably would be more accurate, like after a debridement, like Dr. Adams was saying, if that's an option, where you're going to be able to get some of that tissue. I'm not saying a punch biopsy because that's more invasive than what we're talking here.
Sure.
But if we can get an aspiration or a little bit of like a curetted sample, I think we're going to get a better idea of what's going on within the wound, not just surfacely.
Gotcha.
I agree completely.
Okay.
Mm-hmm.
All right. I mean, a couple of questions came up, and you mentioned it. She might have missed it. She asked if does private companies pay for it. And you did say a lot of commercial insurances do cover it.
Right.
And another gal put up a question, and this may be just one to reach out directly to you, Therese, with your contact information. She asked, and this is my gal from, I believe, I recognize her name. I think she's from over in Europe somewhere.
Oh, okay.
But she's like, do you have any published literature or studies on this? And I'm going to presume you probably have some different types of information.
Yes.
So Iva,
absolutely.
What I would do is when we're done, I will be putting up Teresa's contact information. I'm sure Teresa would be fine if you email her. She would be more than happy to share that information with you. Obviously, Teresa, you mentioned the punch biopsy, which is still by all. What's the word I'm looking for here? I need a speech therapist having a word finding problem. Croatia, she corrected me. Okay, there we go. That part of Europe. But anyways, you were talking about the punch biopsy, and we know it's kind of still considered to be the gold standard for confirming wound infection. Although I really think with enough evidence that PCR potentially could become that gold standard in time. And so anyways, so getting
this
on
is
with,
what we're
what?
No, I was just going to say, this is what we're actually focusing on is looking at these studies. There was a study that was done in 2011, and maybe this is the correct time to put that chart up that we had talked about earlier.
I can pop that up if you want me to.
Yeah, this might be good. So what this is showing is in 2011, there was a study that was done that was comparing traditional culture and sensitivity with PCR testing. Okay, so what you're seeing here is the traditional CNS with systemic antibiotics, and we're seeing healing rates at the bottom. That's what those percentages are. So 48.5% of people healed with a CNS test and systemic antibiotics. When you up that to molecular diagnostics with PCR testing, your healing rates go up to 62.4 with systemic antibiotics. So that you see that's quite a significant increase.
Right.
But even better than that is when you add in the customized topical compounded antibiotics that we spoke about. You see your healing going all the way up to 90.4%.
Wow.
So this study is showing, the efficacy of PCR testing, especially with these topical antibiotics. And these, what we're trying to do as a lab is to extend that study so that we can show that really it's almost antiquated to be using culture and sensitivity anymore, because the technology is out there.
Right.
It's covered, it's available, it's not difficult. And really it's just something that's going to give you better outcomes.
Sure. Excellent. Good
Yeah.
deal.
I've seen that in my practice also.
Right. Those are some astounding numbers,
Right. Yeah, they are.
90%, healing rates or better outcomes is, I mean, who wouldn't want that for
Yeah.
their patient, when you really think about it in the end. So let me just,
Right.
I got to turn it over to you, Doc Adams, for one more question here. And that would be, what advice would you give to a fellow prescribing clinician that may not be using PCR in their wound care practice? What would you recommend to them, or, what kind of advice would you give them?
Well, I am a very practical person, and I do know quite a few podiatrists, and I know that the slow healing wounds are not only uh, uh, create negative feelings for the patients, but they do for the doctor also.
Sure.
My advice would be give it a try. I think you'll be happy with it. There's no downside to it. If you can increase your patient healing rates, you will then not only have a happy patient, but you have less stress in your practice, and you won't lose that patient to another doctor with the patient saying, well, this podiatrist or this physician didn't do anything to help me. There's no clinical change, no protocol change in your office. You would take a standard culture anyway. This is just as easy as taking a standard culture. There's really no downside to giving it a try. There's only an upside. That would be my advice.
Okay. And I'm going to throw one more question at you too, because there was one that I missed earlier that came in, and obviously, as we know, in wounds, generally they're polymicrobial. There's multiple different species of bacteria growing in that wound. When you're doing a PCR test, whether they're doing, the Levine technique where you're pressing it in and squeezing out some fluid, or aspiration, or whatever you're doing to get your samples, you're going to pick up more than just a single species of it. So when you have that polymicrobial result and potentially a polymicrobial infection, how do you know which organisms to treat?
Personally, and again, there may be physicians who disagree with this. I'll take a shotgun approach, and I'll try to get whichever ones are. For example, when we use the lab, we'll get a printout of the different bacteria and the different antibiotics, just like you would on a typical culture, but there's much more detail involved there. So what I'll try to do, if there's 4 or 5 bacteria, I will try to find the one oral antibiotic to get the patient started on, at least initially, until we get the topicals that will kill 4 out of the 5. Okay. And just to kind of hold things at bay until we get the topicals started. Of course, there's always, one organism, a Staph aureus, an MRSA, that you really want to get out of that infection if at all possible. But that's I hate to say the outlier, but if there's not that type of a problem going on there, then I really take that shotgun approach, trying to get whatever appears to be a pathogen.
Gotcha. Okay, fair enough. And again, like I said, there's still a lot to learn out there, especially in this particular arena. And I mean, everybody's going to have different opinions based on their personal experience, their clinical experience, and things of that nature. And obviously, again, another thing is, and this a comment was made by another one of our audiences that PCR is obviously not available everywhere. Where I'm assuming, Therese, that we'd like to get it available everywhere if we could.
Yes,
That
we're
is the
trying.
goal. But we also have to be honest that it's not right now. It's a great tool, but not everybody's going to have that access to it. And so let me ask you this, Therese. So what's kind of the game plan for a company like Ability to try to get it out there and make it more mainstream in wound care, so to speak?
Well, we're going to see if we can get on more Facebook Live interviews with you. That's one way. No, we're really working with a lot of different arenas in wound care. Like I mentioned before, there's the clinic system out there, hospital-based clinics. We do have programs for them because a lot of times it's difficult to get in to that arena just because they're
Sure.
affiliated with a hospital. But
Right.
there are ways that we can help them and help the hospital out with capturing, the billing and everything with that.
Right.
But it's also talking with biologic companies. We've seen a lot of technology out there with new biologics that are available. So it's working with them and their group of people that they deal with. The providers just that go out there and do the wound care, whether they're in clinics or they're with these companies that go into nursing homes and do that. A lot of people in your audience, I'm sure, that do wound care, they bring that information to wherever they are and say, hey, we heard about this. Can we look into it? You have my contact information.
Right.
And it's the conversations and the connections out there, really. There really should not be a situation where it's not available.
Right.
The way we work it is we're international. So, I mean, we're national here in the United States. So if we have somebody, I'm in Illinois, but let's say we have somebody down in Texas, we can get them the supplies. We mail them to them so they have everything they need to do it,
Right.
including the requisition forms and the overnight mailings and everything to get to our lab. So it was about a 3 to 5 day turnaround for results. It's pretty quick,
Okay.
so.
All right, good. Let me throw this by you, Doc. Question just came in from the audience. When do you make the decision to use PC? I know you kind of touched on it when things are not moving along, but what kind of signs and symptoms would you look for that may be more evident that would be a key indicator that definitely we would probably want to bring a PCR test into this? Other than, like I said, we talked about the delayed healing was one of the reasons that you said when you've kind of eliminated everything else that's the obvious, the nutrition, the blood flow, is the wound clean, stuff like that, and be like, okay, so what are some signs and symptoms that you would look for from the wound that would be like, I definitely think we should do a PCR test on this?
Right. And that's, again, a personal approach. But the one thing that concerns me is when I see the clear sheen on a wound, and there's no foul odor. There's nothing that sets off my alarm bells, but there's also nothing I can put my finger on. The erythema around the wound, the depth of the wound. But when I see that kind of clear sheen that makes me think Pseudomonas or something that's not a purulence producer, that's one of my key go-tos. Would be the PCR testing, where I'm just not sure what may be in there. If I open up an abscess and there's a lot of purulent drainage, my assumption goes to staph, and I use an anti-staphylococcal. If it doesn't get better, then we would do the PCR testing. But it's those wounds that just don't present clinically as a textbook picture that I need additional help with.
Gotcha. Okay, that makes sense. Again.
Also, if I can add, sorry to
Sure
interrupt.
can. Please do.
I think anytime a culture and sensitivity is thought about to do, I think your PCR is just going to give you a better idea. Anytime a clinician says, we probably should culture that, it should be, let's get a PCR test because you're going to know exactly what's in there.
Right. Now,
and then we had a picture of a leg wound. that I had sent that Dr. Adams was kind of discussing, I think you can kind of see what's going on when he was talking about the sheen on this. I know a lot of times we say we don't see biofilm, but in this type of a wound, I think it's pretty prevalent. That's one of the things that's going on. And it was actually, I had taken this picture and that's exactly what was happening. But this is kind of a visual to give just to show sometimes what that might look like.
Well, thank you, Therese. I appreciate that.
Sure.
Now, let me clarify one thing too for our audience on the PCR testing. I mean, obviously, we've been talking about, obviously, figuring out what the different species are, their resistance. And to my, and correct me if I'm wrong, but is there also not, doesn't it have some type of a built-in like algorithm that kind of quantitatively determines the level or amount of bacteria?
Yes.
I mean, obviously, it's not like doing a punch biopsy where you grow it out and you know the specific, but there's like it's got a built-in type of an algorithm that can estimate or project what the quote unquote levels of that a particular bacteria are in the wound as well. Am I correct on that? Is that
Absolutely, yes.
okay?
And the reports
and that's
show
very
that.
helpful too.
Okay. So that all comes out in the report then, is along with all that other stuff then, correct?
Right.
Right.
So then you
And
know
for
if
the
it's a
clinicians,
colonization.
Go ahead, Dr. Adams.
I
Then
apologize.
you can come in.
I was going to say, for the clinicians, for the physicians, it's kind of a no-brainer. The report is right in front of you. I go over my reports at lunch, and then I go over the new reports that come in at the end of the day. And you don't have to ponder and ruminate and think about what you want to do. Within reason, of course. There's always those complicated cases, but they'll list, the growth ostensibly as mild, moderate, or severe, heavy growth, light growth, and then we take it from there. The assistance that they provide makes my life much easier.
Excellent. And Therese, did you want to add something to that?
No, he said it.
Oh, he got you. Okay, excellent.
Yeah.
You guys are.
Well, I was just going to say in the report you could see, but just by the numbers, if it's a colonized, if it's infected, if it's contaminated, you know what I'm saying? Because you're seeing those
Right.
quantitative numbers.
Gotcha. All right. Excellent. Excellent. So as we're kind of bringing this to a wrap up, unless some questions come up from the audience, I got one more question for you, Therese. And I know you touched on it a little bit, but maybe a little bit more I want you to kind of go in. So what advice would you give to the audience that may not be seeing PCR testing being used at all or much in their area? And what advice would you give them on how to bring that valuable tool into their practice?
Right. I think all of us as wound care clinicians need to really look at what we're doing with our infection control procedures. We're all being looked at, like long-term care and home health. They have surveys that they do. I mean, it's just a good idea to look at what we're doing with infection control. So as you're looking at your wounds and what kind of infections you're seeing in wherever you are treating them, it's how are you containing that and how are you evaluating that? And I think when you add a technology such as this, you're only going to improve what you're already doing. So I think one of the first things you do is look at what you're already doing and how are you going to make this better? Because everybody's looking for that, right? Everybody that's doing anything in healthcare is looking to get better, so that we can have better outcomes for these patients.
Everybody wants a better mousetrap.
Yes, exactly. So I think that's the first thing. And if this is something that is to be considered or something that anybody would want more information on to see how they can incorporate this or what it would take or what kind of education would be needed to talk about it, it's really just opening up a conversation with the powers that be, I always say, because there's a lot of questions with this, how it's done and what, like you said, the costs and things like that. So it's just, getting the program in place and knowing that this is part of the collaboration of what is already going on out there.
Okay, excellent, excellent. So one last thing, Therese, I know that you have got a free downloadable
do.
tool for our audience, and we're going to put the link up in the comments, and then it will also be up on the Facebook page as well too after the interview. So
Wonderful.
you'll be able to go that. So what do we got for our audience here as kind of a little freebie download that they can get? How's it going to help them?
Well, it's pretty exciting. There's a lot of colors on the page, so that's fun. No, the chart that I showed you that you brought up, showing the healing rates, that's a part of it. There's a little bit more of an explanation about that study on there. But it talks about the science behind PCR, and what we're doing at Ability Diagnostics with this technology and helping, the clinicians out there in getting a program together that's going to tie this in with what they're doing.
Right.
And we have a lot of information. So if any more is needed, reach out. My information's on there
I'm
as
going to
well.
put your contact up, and one thing I remember, if I remember when I looked at the download, there was kind of like almost like a guide, a treatment guide that kind of showed
Right.
step by step, kind of what your results do and what your intervention should be. Am I right on there? Am I remembering correctly? At 51,
Right.
I can't retouch my memory as much anymore.
Me neither. Obviously, I didn't even bring that up. Yes, there is. It's a little bit of a decision tree and how you go about when you have a situation and when when to put the PCR in place and how that affects the outcome of the treatment that you're using.
Excellent, excellent. We appreciate that. So check the link out in the comments, folks.
Yeah.
Of course, it will be up on our Facebook page with the when we send out the video recorded and posted again. So I want to put up Teresa's contact information. So anybody who would like to learn more about PCR testing, what Ability Diagnostics could potentially do for you, here is all of her info. You can take a quick screenshot with your phone. Or obviously you can pull up the video later and fast forward to the end, and you can get this information as well. So I want to just wrap this up and say, first of all, thank both of you. You were great guests. I think you provided some great information. We've got some good comments and feedback in the comments box. And you guys, like I said, I thought you handled everything very well. You gave some really good answers. And I think you helped our audience to better understand really how to use this tool in wound care, not just what is the tool, which is kind of what we covered the very first time that we interviewed somebody about PCR testing. So I want to thank both of you for taking the time to be with us tonight. And any final words that you want to share with our audience before you go?
I'm sorry I didn't have anything free for you.
Not a problem, Doc. So
no, we want to thank you actually for this opportunity as well. I think that it's just important to get the new technology out there and the options that are available to help, especially when you get stuck out there and you don't know what the next step should be.
Exactly.
That there are things that can help.
Excellent. Well, thank you guys. You all have a wonderful evening. And we will chat with you. I'm sure at some other point we're going to bring, I know Doc, we talked about Doc about bringing you back on at a later time to talk about some of the surgical reconstruction work that you do with diabetic foot. And so, but so there's a little teaser, everybody. There'll be another future one. You'll get to see that handsome, sexy man over there on the far side of your screen talking more his game with the repairing and reconstruction. So I'm excited to have that topic come up. So thanks again, Therese. Thanks again, Dr. Adams. You guys have a wonderful evening.
You too. Thank you.
Bye-bye.
And everybody, that is it for Wound Care Gurus tonight. I want to thank everyone who tuned in. And again, check out that link for that free download if you want to go get that. And anyways, until next time, everybody, you all have a wonderful evening. God bless everyone. We'll talk to you later.